And you've, each of you have made contributions in your own way to the field, be it education, or Dr. Tazer and Dr. Murray contributed posters at the AASM scientific program. So each of you are making contributions in your own way to advocate for the field of dental sleep medicine. Um, you're also, all of you are incredibly generous with your expertise and knowledge. And as long as I've known you and seen you in different places, you're more than willing to offer advice or answer questions and are approachable. And I encourage anyone in the audience who has questions to follow up with any of our panelists on any topic, and they're very willing to help. Um, and it's an incredible quality. So thanks all of you for being on the panel and for all that you do for dental sleep medicine. It's an honor. This is actually part two of the webinar series. Part one was a few weeks ago where we got into the science. We had Dr. Remmers talking in more detail about the pathophysiology of OSA, and some of those insights set up the EVO guided program. I will briefly cover that for those of you who may have missed the first series. And we'll also have a QR code that people can quickly link to that first webinar and rewatch it if you're so inclined. And I assure you that Dr. Remmers, when he talks pathophysiology, he's preaching. He's in his element. He's a pig in mud, and it's not to be missed. So if you're interested in learning more about, let's say, the science and the medicine and the pathophysiology behind why Evo Guided makes sense, I encourage you to scan that QR code and watch that webinar when you get a chance. Okay, so a little bit about PreSomnus. We were founded in 2016. Our headquarters are in Silicon Valley, Bay Area. Everything we do is made in the USA. All of our materials are sourced in the USA. We do have a headquarters in Europe as well, in Munich, Germany, which is a service depot for our European operations. But even the orders that are made through Europe are manufactured in the USA, and we ship them to Europe directly. Our mission is 100% success for you and your patients. And we are the leading non-CPAP OSA therapy by number of patients treated. PreSomnus devices were used to treat more patients than hypoglossal nerve stimulation or other types of alternative CPAP therapies last year, which is how we support that statement. And we're very proud to be the leading non-CPAP option. We're the only precision milled oral medical device for OSA. Precision means that our devices are 100% made from your oral records for each individual patient. Our devices do not have prefabricated parts. PH does, because it's a Medicare requirement. It has the Herbst arm. But our Evo devices have no prefabricated parts. They're 100% made on the records that you take for your patients and that you provide to us. We forward engineer our devices to make sure they match your treatment plan and prescription. We use AI robotic manufacturing so that we can measure our manufacturing tolerances in microns versus centimeters. And milling also gives us access to a wide palette of different materials. And, we go through the effort of using a medical grade class 6 biocompatible material, because these devices, we hope that they're used between 3 to 5 years in the mouth. And so they need to be made from a material that can hold up, easy to keep clean, easy to use, easy to wear. We also have clinical and scientific validation. Over 300,000 patients have been successfully treated with PreSomnus devices. 4,500 active prescribers worldwide, and the fastest growing company in sleep medicine. And when we look at the impact of PreSomnus devices being used in each of your practices, it accounts to about $311 million of net public health savings, meaning the benefits of avoiding the strokes and avoiding the comorbid incidents minus the cost to treat yield a favorability of $311 million to our economy. So, of course, the key thing is that people are feeling better and living healthier, better lives. But in terms of payers who constantly want to grind us down, knowing that when you treat someone with an oral device, that it generates a net benefit for the economy is something that payers care about. So we're trying to do our best to monitor that. All right. We also use a unique manufacturing process, which is the graphic on the right-hand side. I won't go through all of it, but out at the end of the process comes an Evo guided device, which is the topic of the webinar tonight. Next slide, please, Heather. So why ProSomnus? Why is ProSomnus the fastest growing? We'll get some answers to that from the panelists tonight, but there are some scientific claims that are unique to ProSomnus devices. These are all claims that you can use in your conversations with referring physicians. The only devices to demonstrate 95% success improving hypoxic burden below the 60% minute per hour threshold. As you all know, anything below 60% minutes per hour is considered normal health risk. Anything above 60% minutes per hour is predictive of elevated health risk for OSA. So it's a great way of knowing, have we successfully treated the patient? At least non-inferior mean disease alleviation to CPAP, which is from the FLOSAT study, and at least non-inferior mean risk alleviation to CPAP in the FLOSAT study. It's the only device to ever, show non-inferiority to CPAP in any way. In a head-to-head crossover trial, 89% success reducing all severities of OSA to an AHI of less than 10, and that was an Eddie Saul paper. Thank you, Dr. Saul. I think Dr. Smith contributed some patients, and Dr. Carollo contributed some patients to that study. Thank you very much, along with Dr. Desai and Dr. Murphy and a couple others. 91% success treating snoring in a prospective randomized controlled crossover trial published in JAMA. So a nice reference there. And greater than 90% preference in a head-to-head crossover trial comparing ProSomnus treatment with traditional oral devices done by the military group out of Fort Eisenhower in Georgia. No dental side effects in two separate 2-year longitudinal studies, one done by Nicola Varanis out of Calgary, along with Jean Santucci at University of the Pacific. Another one done out of India, Dr. Aziz, along with Professor Kala, showing no changes to overbite, overjet, crowding, etc. And then a third-party independent study done by Intertech showing less staining than a CPAP mask, the only device to demonstrate less staining than a CPAP mask in an accelerated aging study. An excellent safety record. Less than 1% of the FDA's adverse event claims involve a ProSomnus device, meaning 99% of the claims involve traditional oral devices that include prefabricated parts or nylon, thermoplastic, acrylic, or elastic materials. So I think those are some of the reasons. Hopefully, these claims are more than just scientific claims, but they resonate with the clinical experience each of you are having. But nonetheless, it's, these papers, you can have access to them, use them with referring physicians, put them to work. If they can be used to help grow your practice, that's wonderful. That's why we do it. Okay, next slide, Heather. I think this is an opportunity for all of us. There's no perfect therapy out there. So there's a need for better OSA therapy. Johan van Braken and Winfried Renderoff, two kind of thought leaders out of Europe, just wrote a nice op-ed in a journal saying there's a dramatic need for new and better OSA therapeutic options, including oral devices. But this need is our opportunity. Even though we've got really good results for oral appliances for compliance, safety, and cost, efficacy continues to be the biggest barrier to more referrals from physicians. And I think that's something that you would all agree with if you had to figure out why are physicians reluctant to refer. It's their concerns over the efficacy of the therapy. Okay, next slide, please. Just going to bang through these really quickly as a review. So our mission is 100% efficacy. And is that possible? Don't know if we'll ever get to 100%. I think Dr. Smith gave a really nice testimony saying probably won't ever get to 100%, but we're going to get pretty damn close. And the study from Watanabe out of Japan shows the potential. He demonstrated 94% success treating severe OSA using a manual jaw thrust maneuver to advance the mandible. And the reality, though, is that when we put a traditional oral device in the mouth to reposition the mandible, success drops below 65%. So why the 29% difference in success rate? And, that's just a factoid that, in my conversations with Dr. Remmers and others, just kind of thought that kind of bothered me. Like, why are we dropping 29%? Why is manual jaw thrust more efficacious than traditional oral appliances? And it kind of raised the question of, do traditional oral appliances introduce counterproductive dynamics? Productive dynamics in terms of advancing the mandible, but are they doing other things that maybe limit success? And that's really what led us down this path of the EVO guided program. Try to figure that out. Next one, Heather. And so we looked at this, some of the kind of the pathophysiology. Not surprisingly, that's what John does. That's what he loves. And kind of the key takeaway here for me was really that OSA is two diseases. It's really velopharyngeal dilation as well as oropharyngeal dilation. And I think Dr. Smith, you say there's it's a 3-in-1 appliance. It treats sleep apnea, it treats snoring, it's a orthodontic retainer. Well, maybe now it's a 4-in-1 because it's velopharyngeal dilation, oropharyngeal dilation, plus snoring, plus orthodontic retention. But that's kind of what the data shows are two separate diseases. And the next slide, please, Heather. This was recently confirmed. Well, sorry, I missed my sequence here. Sorry, but this chart shows that mandibular advancement, this study by Olivan shows that mandibular advancement does a really good job of dilating the oral pharynx, but a relatively poor job of dilating the velopharynx. So it treats one of the two OSA diseases, but not both. Next slide, please. And the literature confirms the limits of traditional OA on VP dilation. Dr. Ryan Seuss, who many of us saw at the Transform conference a few months back, just published a paper where he looked at 35 patients with incomplete response to traditional oral appliances. He put them under DICE to identify the collapse location and found that 43% of those patients had persistent velopharyngeal collapse with DICE and with oral appliance therapy. And the traditional oral appliance that they used had a lot of bulk on the lingual side of the device, potentially pushing the tongue backwards or preventing the tongue from coming forward, which then pushes the tongue onto the velum and prevents the velopharynx from dilating. Next slide, please, Heather. And this is a study by Sestuli's group showing that with a little bit of beneficial anterior tongue posture, the response rate goes up tremendously. And if you have a little bit of counterproductive negative tongue posture, the response rate goes down tremendously. So very important to take care of the tongue with respect to trying to create space to open up the velopharynx. Kind of more indication that the oral appliance has to do more than just treat one disease if we want to chase 100% success. It's got to be engineered to treat both diseases, both dilate the oral pharynx by pulling the mandible forward, but also create room for that tongue to come forward to dilate the velopharynx. Next. Thank you. And this is a study, Vicki Cohen was part of Dr. Cohen with Andrew Wellman's group, showing mouth closure is linked with elevated success, the increase in response rates with the mouth being closed versus the mouth opening. And the argument there is that it lengthens when the mouth is closed or the teeth separations are minimized. It stretches the dilator muscles for the pharynx. And when the teeth are separated and the mouth is open, it shortens those pharyngeal dilator muscles. And Professor van der Vieken out of Belgium also published a study recently, a head-to-head study, and made similar conclusions, showing that the device that had passive mouth closing features was more efficacious than one that was more oriented towards separating the teeth and keeping the mouth open or keeping the lips open. Next one. And this is just a slide that kind of talks about the materials that we try to use. And we want patients to be happy and to wear their devices every night for 3 years or for however long until we can get them a new one under insurance. And so we want to use a material that can hold up and isn't likely to stain or accumulate bacteria or other things that could be a risk to oral systemic health. All right, next one, please. So just a summary here. So an oral device that's designed to treat the velopharynx and the oral pharynx is one that can consistently dilate the oral pharynx by repositioning, stabilizing, and titrating the mandible with micron precision, to consistently and predictably dilate the oral pharynx, and that's more of what a traditional oral device is intended to do. It should also encourage a forward tongue posture, hence make the device lingualist to enable anterior tongue posture, maintain the natural contact pressure between the margins of the tongue and the lingual sides of the teeth to dilate the velopharynx, minimize tooth separation, to minimize the vertical direct dimension, lengthen and stretch those pharyngeal dilator muscles to promote lip seal and nasal breathing as well, and then use medical grade materials that can stand up for whatever the period of time is that insurance says that the patients have to wear the device. So that's what we were aiming for in terms of design goals, engineering goals for the EVO guided program. Next slide. This is that QR code. So I went over it, hopefully I went over it pretty quickly, and for some it's repeat and probably boring for others. You might be new to it. We've got quite a number of new names on the webinar tonight, which is wonderful. So if you want to hear more detail and you want to hear detail delivered by Dr. Remmers as opposed to me, click on that QR code and watch that video when you get a moment. I think you'll be glad that you did. So thanks. Heather, next slide. Okay, so this is the EVO guided device. It's overall a smaller device, 4 times lower profile in terms of the titration mechanism. Quick question, Dr. Federici, how would you describe the EVO guided in terms of, let's say, the other EVOs or other devices in terms of volume and profile and size?
Yeah, thanks for having me tonight, and great to be with everybody here on the panel as well as all the attendees. So yeah, obviously less bulk, more real estate availability for the tongue. I've had patients who have had the traditional previous generation EVO and were given this one and can definitely, like, as soon as they put it in, they could feel that extra space. So what I've been starting to do is do a little less titration. So I do some pulse ox testing, and then I actually start this new appliance 1 to 2 millimeters less titration than the previous one left off of, and I'm finding no changes in AHI needs to keep titrating forward. So literally, a thinner appliance, less vertical, is getting the job done with less protrusion, which then will mitigate majority of your side effects, right? And as Dr. Tozer and I were talking about, there's going to be some data coming out shortly that over protrusion of these appliances are causing a great increase in nasal airflow resistance. Here we are trying to promote nasal breathing, right? And now we're over protruding due to bulk of some of these appliances, which is now combating our desire to lower the AHI, but again, increase or side effects. So it's all great news, and I've seen nothing but great results for my patients have upgraded. Obviously, first-time users are loving it. They don't know any different. I've had a lot of people who use older, antiquated devices that just love the thinness, the least amount of bulk, the space for the tongue, and the less titration. So nothing but high marks.
Can we maybe spend a beat on this titration or starting position? Anyone else finding that they can take a more conservative approach to where they start the patient?
Yeah, I'm sorry, Dana, go ahead.
I was going to say, I'll add here, we need less vertical opening in the posterior. So I learned the hard way. We used to think, oh, we have 3 millimeters in the back. All we need is 3 millimeters in the front. And of course, patients have curve of Spies. So now I'm finding we don't have to open their mouth as far. So tagging in with what Dave said, then there's less chance of open mouth breathing. They're able to breathe through their nose because their lips can close. They don't have problems with over opening that we need with the thicker appliances. And then of course there's room for the tongue, so we don't have to increase vertical or protrusion as much.
Mm-hmm. That's an interesting point. Dr. Carollo, you were going to add something?
Yeah, so, with having more tongue space, I'm finding out the same thing. What happens is with a lingualist design, some clinicians always call it the tongue box or the space available for our tongue to be positioned. And so an interesting thing actually happened today. I was thinking about the webinar tonight, and my new patient today comes in with he doesn't fit the typical sleep apnea patient, very thin, healthy young man, early 40s, yet he's got high vaulted palate, very, very narrow arch. And I'm thinking, if you have a thick appliance on that guy that's going to be all the way on the lingual, covering all his teeth, his tongue's going to fight that space to begin with, and I'm going to have to put him more forward. And so I showed him the Evo guided today. I said, this appliance in the webinar I'm going to be part of tonight is actually going to be your perfect example why having a lingualist design will allow your tongue to go more forward with less protrusion. And we're going to start you off very conservatively and then see if we even have to go forward at all.
Yeah, a great point. And Dr. Utterback, if you don't mind commenting, would you view Evo Guided as a frontline device or a device maybe for patients that have a certain phenotype? How do you see it fitting into your practice with respect to patient selection?
I have found that it's definitely become my appliance of choice. I've even found that patients whose insurance requires a herp style appliance will have the talk, and I'll tell them I've been using this appliance for several months. The results we're getting are just absolutely incredible. And after we have that talk, I think a lot of them feel that, you're the expert, you know what's working well for your patients. And I find a lot of them then will say, I'm going to trust your judgment. And it's definitely the front. I mean, I was a huge fan of Evo Select. So making this transition at first, it's something new, but I would agree with the other panelists that we're finding that the biggest thing I see is that patients don't need that couple weeks to adjust to wearing it. I don't hear the sore joints, it's something foreign in my mouth. I feel like they jump on board. They do really well with it right away, and therefore we can really focus on, getting them to the end point very quickly.
Thank you for those comments. Dr. Smith, how does that jive with what your practice is hearing when if patients are beginning to come back for their first recall appointment after delivery?
Well, yeah, I mean, a lot of this is anecdotal stuff, right? Because you're hearing from patients, and I'm quizzing my assistants who quiz patients. And, we've given out a lot of surveys to them, those that have had prior appliances, and they've been filling out these surveys. I don't have all of the data that I can share yet, but so far it's looking very promising for the Evo Guided, which I expected. But I trust myself even more than a patient. So fortunately, I've had a lot of the different iterations of the ProSomnus appliances, and I wear this cool upper arch with this monitor in it,
Yeah.
and I wear it with the lower, but I've changed out the lower with this one, and then with the other Evo styles that I've had, and my ODI goes higher when I wear the other style appliances. So that's just in my own mouth. We've got a research associate now in the practice, and we're going to be doing a lot of research here with before and after studies with different appliances. And so again, this is a little early in the game, but I'm feeling really good at this point.
And thank you for your comments, but thank you for having the research. So it's going to be fantastic with the diversity of patients that you treat and the volume of patients you treat. It's going to be a wonderful contribution. Are you still getting 100s on your nightly sleep score, by the way?
Yep.
Oh, man. We were at the AASM in Seattle, and I'm wearing the same thing. And every day I would see Dr. Smith, and he's like, "I got 100, I got an 86." He's just trolling me the entire time at the AASM. I think our engineers gave Dr. Smith an easier algorithm for getting
No,
100.
no.
That's my
I have healthier
story. I'm
sleep.
sticking to it. Wonderful. Dr. Tozer, I know from your poster at the AASM, you monitor these things closely. How's Evo Guided doing in terms of your protocol, your rapid titration protocol, and your approach using oximetry?
Yeah, thank you. One of the things I found is I hit the sweet spot sooner, and what I'm running is a head-to-head competition.
Yeah.
Well, it's tough competition because I'm doing a guided against an Evo, both fantastic devices. But what I found is I hit the optimal titration sooner. So that's good for the patient. We get there quicker. My comment too is I'm big about titrating and while we are testing while we titrate. And my comment is if we're not testing while we titrate, it's like driving down the freeway and spacing out and missing your off ramp. You'll get there, but you got to turn around and come back. So I'm big about testing as we go because what I have found, like some of your other ones, is when we exceed the optimal, we actually degrade our response. In fact, sometimes, and this is counterintuitive, if we hyper advance them, we actually degrade them. Some people worse off than where we started. That makes no sense to me at all, but I have found it. So we don't fall asleep on the off ramp and miss our exit. I really believe in testing as we titrate so we can find that spot. And what I'm finding is with guided, I find it sooner.
Yeah,
Get
that's
the patients done sooner. They're happy.
yeah, Doc. We got to get you a Tesla so you don't miss those off ramps.
You know, one of the questions I'd like to throw out to the panelists is the notion of mouth closure and nasal breathing. And I think first I'll direct this to my good buddy Dave Federici, because we've spoken about this a lot. And so, David, I would ask you, with the Evo guided and the evidence to suggest how important nasal breathing is and mouth closure, how do you feel this has impacted your patients in your experience so far?
So yeah, you know, even with the Evo with the 90-degree posts, which on itself was enough to prevent jaw drop, right? But you find out some patients sleep with several pillows, so even at 90 degrees, those posts can somehow slide down when they get to REM sleep. So with the additional 5 degrees, I always tell the patient with this appliance, the appliance actually has to go uphill a little bit before it can have the jaw drop. So with the extra 0.5 millimeter of less vertical required, plus the angulations of the post, I don't add hooks or anything for elastics on my appliances, which for the mouth pursing type person who has a lot of orbicularis oris movement at night, they're not rubbing the inside of their lips on those hooks, hoping that we were going to end up needing them at some point in the titration, right? We can always cut them off later in the process if we didn't end up needing them. But right now, it's automatic for me not to even include those. And especially for a patient who has poor dexterity, asking them to use tweezers or to find and try to hook an elastic on is very difficult, right? So that's one of the benefits is, hey, I envision this patient possibly needing elastics, but she can't do it. So again, there's another requirement or a checkbox for an Evo guided will help actually with the lack of jaw drop and maintaining that closure.
Just a quick comment on that, if you wouldn't mind.
Sure.
We converted a lot of patients over from another appliance to the Evo guided, and quite a few have complained that it doesn't have the elastic hooks. But when we see them at follow-up, not one single person has complained about no elastic hooks or dry mouth or jaw dropping open or anything. So I think you'll find that patients do get concerned if they're moving from a different appliance, but they shouldn't be.
Is everyone else feeling the same? Anyone missing the elastics or missing them for certain types of patients? Everyone pretty much okay with proceeding without elastics, taking benefit of the little less vertical requirement in the 95-degree post? Is it working okay?
Yeah, I find the same thing that both Dr. Federici and Dr. Smith said, that the posts having that extra 5 degrees. When a patient has to put it in, because of the design having the lower post slightly longer, you could put it in sort of together as a sandwich. If they put it in separately, I'm finding they just have to go a little bit more protrusive to slide into place sometimes. But once they're in place, they go, wow. They actually talk different with it in place. When you give a patient like an Evo Select, they can actually speak more clearly. With this here, it's almost preventing them to speak clearly with the device in their mouth because of the fact that it's keeping them more closed. They sound more like a ventriloquist. So it's kind of really telling me it's working, even when they're just sitting there, and then they come back as others have said on the post-op visit, saying that, wow, I feel like I'm breathing through my nose better and everything. Of course, we always test for nasal patency as part of our examinations, which is the most imperative thing to start with for all of us.
Yeah.
Dr.
If I could, I would agree. My experience so far is the same as well. Our initial follow-ups, patients are still on a 0-0. And yeah, we're not getting the dry mouth reports as much. And we're getting a lot of, hey, I'm being told I don't snore anymore, a little sooner than we were even with the Select. So the initial follow-ups have really been positive from all of the patients. So that's really been great.
Well, Dr. Murray, thank you for taking care of my people in Connecticut.
Absolutely. Doing our best.
Thank you.
You know, if you think about it and you go back to the paper that showed that a jaw thrust without anything in the mouth achieved a very high level of efficacy, you can work backwards and say the smaller the appliance, the more room for the tongue, the less vertical, the more it promotes nasal breathing, the higher the efficacy. And you look at a paper that we published before, and we looked at all the different designs, and the efficacy went from, and the lowest efficacy was the herpes appliance. And, you know, clearly, why is that? And the answer is it cannot be maintaining the position that's prescribed and the jaw opens. So I think that it's great that everybody in the panel here is seeing that you don't have to protrude the jaw as far forward. And you know, I think when we first started at ProSomnus in the Micro 2, the IA, I think that a lot of clinicians were bringing the jaw a little bit further forward than they needed to because that was in their DNA, that how far you had to bring the jaw forward. And the hope is with the Evo guided that what we'll see is maybe even less protrusion than the previous models that we've introduced.
Yeah, Eddie, we still see a little bit of that in Europe where they're a little bit behind the US in terms of changing over their technologies. They're still stuck in the 70% max protrusion, modality. And when we say, yeah, well, most of the more successful people in the US are taking a more conservative position, 40, 50%, they're like, you Americans are crazy. It's the classic stuff. But yeah.
If I can add something into this, so I've been tracking, so I've done a lot of these guided, and I'm always been a conservative start point guy, right? My philosophy is I'll mitigate side effects and I'll catch those early responders. And, historically, I would have pretty decent results right out of the gate. And the traditional Evo provided me 5 millimeters of protrusion. So if you start more conservative, it's nice to have 5 millimeters. And of course, the Select and the guided only come with 3 millimeters. So my concern initially was, wow, if I start at 30% and I only have 3 millimeters of protrusion with these trays, I'm probably going to be ordering some additional arches at some point, right? That's the thought process. Being more conservative and you have a wide range of protrusion yet to go. Now, it's okay if majority of the people listening to start at 50%, but why wouldn't you want to try a little less, to mitigate side effects? If the number one problem we're hearing from sleep physicians is patients coming back with pain after seeing a dentist who wasn't qualified and might have over protruded or started too much, roll them back a little bit. And trust me, I've done a lot of cases so far, and I have not yet to have to order an additional arch with this system. And it just can't be luck. If you did 5 or 8 or 10, but when you're doing 40 and 50 and 60 of these and not ordering one additional arch, starting at 30% protrusion, that's telling me that it's the appliance that's doing this now. It's not some magic that I've got 50 straight patients who only needed 40% protrusion to find their sweet spot, right? I mean, it's the law of averages. So that's what's really sold me on is case after case, initial positions of 30 and 35%, reducing the HIs, sometimes 70, 80%. And I'm not talking like 12s down to 7s. We're talking 40s down to 9s, right out of the gate. So that's telling me something that these patients need this real estate tongue space, and this appliance and its all its characteristics are providing what it needs to get the job done sooner with less side effects.
I'll say internally, we haven't done very many additional arches. We haven't had very many additional arch requests, but we weren't sure if that's just because it's new and people haven't gone through their titration sequence or whether it was because there was something unique about the design. Yeah, and we hope there was something unique about it. We hope that the additional tongue space, the reduction of vertical, the 95-degree post would result in, and let's say more conservative, successful outcomes with more conservative protrusion. So we'll see how that plays out over the coming months, but it's off to an encouraging start. Thanks, Doc.
I'd like to throw this out to the panelists. You all work with referring physicians and you hear things such as oral appliances don't work, or how do I know it's going to work? And they work 50% of the time. So if you take the design of the Evo Guided, you feel more confident when you speak with your physician colleagues that you're going to get a predictable, reproducible response with minimal side effects. And maybe just one by one, everybody can comment on that.
I'd like to add something here too on that same note. Think about the complaints that either the patients have to their physician about CPAPs. The mask doesn't fit. They have dry mouth. They can't wear it. They have claustrophobia. So the nice thing about this, we can be sure that they're not going to have dry mouth because they're going to be able to breathe through their nose. And they're not going to have that sensation of claustrophobia because their tongue isn't going to be cramped because of the lingualist design. So, in talking with physicians and providers in the medical offices, I'm able to reassure them that we're going to put something in the patient's mouth that is going to be much more acceptable to them. So, I hear the same complaints. We all do the same complaints that patients have day in, day out, either about their CPAPs. Some will also complain about night guards that their dentist put them in because they grind their teeth, and they hate those too because they're too big and bulky.
Mhm.
So it's just very reassuring to me to know that we have this device that has, to me, all the bells and whistles to improve the ability of the patient to wear it.
It's a very interesting point, if I may say, just that, presenting it to the physician as a contrast to CPAP. It is a foil against all of the things that the patient doesn't really like about CPAP. It's a really nice way to position it. And when I was going to introduce you, Dr. Blaylock, I was going to describe you as a very, very wonderful, pleasant, nice, soft-spoken person who's also an absolute shark when it comes to this stuff. And that's just your comments there are just a perfect example of, very calm, demeanor, but right at the critical issue. And so thanks for sharing that.
Thank you.
You got it. Got it.
Dr. Saul, if I may start on your question. So
Sure.
talk about physicians, right? And their acceptance of therapy. I had a patient who went to their cardiologist who was a severe, who couldn't tolerate CPAP. She goes, I'm coming back to you now because I had oral appliance. And before she could hand the doctor the titration report showing our success from a 41 down to a 8 point something, he says, what'd you do that for? Do you want to die? Like, he told the patient that, how dare you even attempt an appliance? Do you want to die? Like, those things don't work. She goes, I beg to differ. She handed this, and the guy's eyes lit up. He goes, wow, I'm really going to have to reach out to this doctor because I have the following preconceived conceptions about oral appliances, right? And when we talk to doctors about the precision, the milling, the exactness, the contours, that the tongue accepts this shape of the contours of the appliance like it's their own teeth, and the vertical and the space for the tongue, and we use pulse oximetry like Dr. Tozer was saying, they're wowed. And it's unfortunate it has to be one doctor at a time, one cardiologist at a time, one pulmonologist at a time, one sleep physician. We just hope they all talk. And most of these doctors are on staff with other doctors. So when we have success with one, I really entice the listeners to really say, could you please spread the word to your fellow doctors who are on staff at your hospitals, whether it's weight loss people or endocrinologists or gastroenterologists. They all need to know about obstructive sleep apnea, and we make them better doctors because until they fix the underlying situation of this, the comorbidities of obstructive sleep apnea, their patients cannot be fully fixed by their specialty, right? So it's imperative for us, literally one doctor at a time. And yes, some of us are more confident than others, and this is why education is so important for every dentist out there, is to get as high level as you can, so you can have these high level conversations. And when you have a cardiologist saying, what, do you want to die? And the patient hands them the pulse ox reports, that's the best vindication we have for oral appliance therapy, right? And it's a ProSomnus appliance. I make sure I write it. So I've had people say, yeah, I looked up that appliance. It looks very interesting. Can you come in and talk? So that's how all these conversations roll, and the industry rises, is by one doctor at a time, one staff at a time, one patient at a time, and changing the thinking of these doctors. And unfortunately, some of them are in old school. And I don't know what the rest of you guys run into, but that's my story of the day today.
Yeah, David, I couldn't agree with you more. And I think the problem is everybody on this panel, you've built successful practices, and I'm sure you send letters to your referring doctors. But, honestly, do they read the letters? I mean, sometimes you got to just pick up the phone and do what you just said. And then they say, wow, this Dr. Federici, he really knows what he's doing. And I had no idea that they could be this successful. And I'm going to refer him patients because he's using whatever he's doing. They may not understand it. He's getting results that go against what I've always felt is the norm. Anybody else want to comment on that? Does it give you more confidence to go to your referring physicians? Because you're all really bright people. And I think when you approach them that way, they're going to step back and say, boy, I need to really consider this more for my patients.
Yeah, my practice, as you know, is probably almost 100% physician referral. We've already pretty much, after doing sleep dentistry for so many years in our practices, just working with sleep physicians on the referrals. I mean, some new patients, of course, come in and get screened. But one of the things I do, and when I talk about working with sleep physicians, is to get in their face at least twice a year. So recently, we're getting some new Evo guided samples. I've actually got on the phone a couple of times so far and talked to some physicians, but the next step is to go meet them, show them it in person, and let them see the difference. Because like you said, Dr. Saul, if they don't read letters, but when you're sitting on talk, they're one-on-one. And I do a lot of breakfast meetings if I can, because it's hard for them to break away at lunchtime. So I'll sit with them for 15, 20 minutes in the morning with some literature from ProSomnus, showing some of the efficacy studies, showing the actual device, leaving a sample for them. And our referrals have just exploded with referrals from the people, because they realize that we're using precision devices, having better efficacy. So it's like win-win-win in all the regards working with them.
Dr. Saul, we've got a couple of, oh, sorry, if anyone
Sure.
wanted to build on that, go ahead.
I was just going to say, after listening to Dr. Remmer's two webinars I was on speaking about the pathophysiology, I mean, that alone gives you a level of understanding that many physicians may not even be aware of. And when you're able to speak to that, it kind of separates you that, hey, this isn't just someone here that doesn't really do this much. Like, they know you're serious. And it's important to bring in follow-up studies. I always do that, bring in a couple of successes and maybe one or two that, hey, we didn't get as great as we wanted to, but to let them see what we're doing. Because most physicians have no idea what oral appliance therapy, precision oral appliance therapy is. They think of the legacy appliances of, well, I heard about this years ago. It's completely different now.
Yeah, completely different now. Well said. Well said.
I'd like to make a suggestion too. Those that haven't tried it, and everybody here on the panel has, but anybody else listening, go ahead, docs, make one for yourself. And Len, you can speak to that. I know you have a special program for that. But if you have one yourself, you'll notice the difference. And you'll notice the extra space kind of draws your tongue into it and opens it up. But it gives you a level of confidence when you go meeting with the physicians. Hey, this is the one I use. I have one of these. Let me tell you why it works better.
Great suggestion. A couple questions from the attendees, if I may. Dr. Saul, first is, I think, a question for Heather. Can the studies or articles be provided to us if we'd like to use or read them as an example? And how would they get those?
Yeah, so I answered a couple of them. So if you want additional studies, just feel free to send an email to events@prosomnus.com. I'll put it in the chat, and then our team can reach out and provide. I think a few folks wanted a link for the prior webinar versus the QR code. So if you just reach out to us, we can have a team member send the link, and then all the studies as well that we've discussed.
Sorry, go ahead.
Well, we have 15 clinical studies now. I think it's 1,453 patients, something of that number. And the mean efficacy was 85%. And this was before the EVO guided, and this was with AHI less than 10. But I think certainly that slide or those references would be outstanding when you go speaking with your physician colleagues.
Right on. Another question from the participants. So regardless of vertical, do you generally start at 50% max protrusion with EVO guided?
My answer is no.
We start them at 50 only if they're severe. And if
Okay.
they're not severe, sometimes we'll start them at CO.
It's CO. All right.
Yeah.
Yeah,
You know,
we
it's
don't,
interesting when Mark Brahm's paper that he did in Belgium, where he did MCP -2, and I think I can't remember the exact number of patients that were treatment complete at MCP -2. It was about 60% of the patients, I believe,
Yeah.
in that study. Uh, and that was a protocol that was used through 6 different hospitals in Belgium, where they standardized things, and pretty remarkable results, actually. And certainly we could give you that reference if you wanted as well.
For sure. It'll be I think it's being reviewed for a medical journal publication as we speak. And so hopefully it'll transition from abstract form to manuscript form here in the next couple of weeks. It'll be a nice contribution to the field. Another question from an attendee is, I think maybe for Dr. Tazer, how do you test while you're titrating? Are you using pulse ox or HST, or how do you do that? Or if anyone else is doing that, what's your method for testing while titrating?
Yeah, I test with the Balin ring. I like it. It's simple. Patients don't screw it up. And we go and test them while they are titrating, so I don't miss that sweet spot. And it's simple. They wear the ring, and I also solicit the subjective symptoms they write down. Ironically, their favorite ends up being my favorite most of the time. In fact, we have fun. We give them a little happy face sticker to put on their favorite combination, and I'll sit down and go over what they liked, and I'll show them the test results, which we're getting in nightly. And most of the time they match up. But my point is, if you're not testing while you titrate, you'll miss that sweet spot. It's only a millimeter difference.
You're using oximetry, Bellin with a Bellin ring. That's the way you're doing it. Yeah.
Ellen oximetry, and I guess they're going to be coming out with positional later on, and also get a hypoxic burden number, which would be nice.
Very nice. Anyone else doing oximetry testing along the way while titrating?
Yeah, that's what I use, high resolution pulse oximetry every 7 to 10 days based on the age of the patient, and validate with 2 nights testing. I switched out from the Night Owl due to the reconfiguration, the problems and the expiration dates, and the customer service has gone downhill. So I used the new Prana Q tip track, which fits what I need perfectly. Patients will take them, and guidance. No longer do I go by subjective symptoms. Some people used to come in kissing my hand, thanking me so much. I feel so much better. And then you get the efficacy test, and we've only reduced their AHI by 50%. So why put yourself in a position to have patients sent back to you because you went by the patient's symptoms? I tell the patients, we move you forward. We let the data drive the endpoint of your advancement. So you'll be much, much, much closer to the efficacy test results. So when the sleep physician gets it, they see confirmation, he's good, she's good, they're good, not 50% go back to Federici. Got 70%, I need more, go back. This stuff. So I guide it along the way, I control it. And then 92%, I think, of my efficacy tests are still where I sent them, and I'm basically done. And that looks like I'm doing a very thorough job, because every other patient is not having to go back to see me for titration based on the efficacy test results.
And are your physicians grateful for you to do that? Because at certain times in certain conferences, there's a political, turf war about testing and things like that. But are they generally welcoming you of doing kind of oximetry for the purpose of titration studies, or are they kind of nervous about that?
Well, I tell them I'm just getting my appliance as close as I can to its endpoint with data, so you don't get haphazard results. And then you go ahead and do your efficacy tests. So I'm not taking away that interpretation fee and that efficacy test they're running, because they want to use their own type 3 tests, whatever that may be. So my job as the dentist is get them as close to that ideal position as I can, due to data, not just random subjective symptoms. The patients may say they're feeling better, and then it just doesn't show up on the efficacy test, and it makes me look like I was kind of incomplete or rushed them through it. So I like to be thorough that way, if that makes sense.
Dr. Smith, you finding similar thing if you're using oximetry, the physicians are supportive of that? They don't feel like you're infringing on their turf?
No, I'm in a little different situation, but yeah.
We fire them.
Right. Hire like
we only use pulse oximetry if their T90 is 2% or greater in titration. If their T90 is not that bad, then we'll go with Wesper with our titration studies. But yes, we do follow-up titration studies. Yeah.
One of the things I'm careful of is we never call it a test.
Yeah.
It's an airway monitor, calibration, titration. I don't want to create friction with the referring doctors. So half the sleep physicians I work with that I've worked with for a while, they say, hey, that's good enough for me. If you're happy, we're happy. And the other half want to get them back in for their test.
Great.
On that note, ask your physician. Some will say, oh, yes, I want to do all the sleep studies. Others will say, hey, I don't have the manpower. I don't have the units, and they're not making that much money on them. And they just want to make sure that the patients are getting better. So I have many physicians, my sleep docs, who just say, just send me the report so I know that they're getting better. But it's case by case. So ask your doctors what they want. But then on the other hand, yes, tiptoe around and said, I did a pulse oximetry test, and these are what we found. And if you want to do a sleep study, they're ready. But just ask the doctor.
Yeah.
Yeah, to Dana's point, I find that quite often we use the Bellin or even sleep image for our titration test. And so it's a very nice report the physician gets. And many times they're happy with the report they see. But we leave it up to them and tell the patient you should have that discussion with your physician. But here's our result that we've gotten. So, yeah.
I might be just a little bit more conservative than most of the panelists. I'm finding that with patients, we look at everything more than just the AHI, of course, but when I'm finding, just if I look at AHI numbers, if the patient's a 15, 16 or less, I really don't do a lot of the titration studies on those patients. In the past experience of when we finally get the final efficacy study from the physician, we're pretty confident that we can take those patients from 15 and less to get them under 5. So it's I go a lot where it's just where I know I think they should be, and also some of their subjective symptoms, and then we're pretty much confident let them to do the efficacy test. I'm finding that in treating the more severe patients, the AHIs of 40s and 50s, we're doing the same thing. We're trying to get that calibration or titration going during that, so that they don't go to the sleep physician and it's not giving us the efficacy, and then we're playing like a ping pong going back and forth. I like to try to get it where I want it to be, so they do that one efficacy test and everybody's happy.
The only thing I'd like to add is, I'm affiliated with Dr. Lehman's office, and we do about 200 or so sleep studies a month, maybe more. And we've used several devices, sleep image, SomFit, Wesper, Watchpad, you name it. We've gone through different ones. And, one of the challenges when you do titration studies and efficacy studies is the night-to-night variability. That's why I'm so personally excited about the RPM. I mean, we just know that, say you're titrating a patient and you do a 2-night study, and one study shows an AHI of 14 and one is a AHI of 6. Okay, are you treatment complete? Are you not treatment complete? And so it's difficult, even with multi-night studies. So, hopefully when the RPM O2 is introduced, it'll completely change the way how we manage people through the titration process.
A related question in chat here is, how soon after delivering the appliance do you do the sleep study or begin the pulse ox testing?
Dr. Murray, what would you say about that?
So I have not adopted Chuck Tozer's protocol yet, but so we typically will wait till we get to a follow-up spot where we've had the best symptom relief, which usually tends to be maybe around 6 weeks, 6 to 8 weeks. And then we usually do a titration test at that point. If the results are not where we like it to be and we're going to advance further, then we may do a second titration test maybe 4 weeks after that. So not doing the protocol yet of Chuck, but I think I'm going to be bringing that in pretty soon.
Anyone else want to comment on that? Dr. Blaylock?
Yes, I normally do the similar thing. We base how they're progressing based on their subjective symptoms. And then roughly 2 months, 8 weeks or so. Now, if I have a patient who has severe sleep apnea and they have many other medical issues, I want to make sure they're getting better quicker. So I may test sooner. But normally I hit them around 8 weeks because I think it takes that long for their airway to start to improve. Their snoring may improve, but they have to heal. They have to
Yes.
make up for sleep debt. They have to work on their sleep hygiene. All of these things need to improve. The oral appliance, as great as this appliance is, it is not a magic wand. I feel like the patients need to do more things to improve their overall health and their sleep. And then we test them, and then they can see the benefit of everything they're doing to help their health.
I kind of agree with you, Dana. The only thing I don't pick a date from when I insert the appliance. I usually like to
No.
wait the 8 weeks from when I'm at that final protrusion position, whether it's just the 0, 0 or an upper 2, lower 0. From that point is when the clock ticks for me. Then I say, okay, about 8 weeks, let's get this study done then. So it's the study's 8 weeks sooner, sort of right after my final position, not from the date of insert, because sometimes there's a lapse in people. They don't come in for 2 weeks or 3 weeks, or my schedule doesn't allow it. So 8 weeks from the day of insert, it's not the answer for me. It's 8 weeks from the final position of the titration of the trays that I'm going to keep them at. That's when I'll test it.
You
Oh,
know,
true. True. And some patients, it may take them a month or two before they even start wearing it regularly.
Yeah.
You know, they get sick, they travel, they've been in the hospital, they have had knee surgery. They may say, oh, I don't feel like dealing with it. So, granted, we normally say once you're wearing it successfully, then we look at it to do the retest in a couple months after.
to just pivot for a second because of time constraints, uh, maybe we should approach the subject of ease of delivery and staff acceptance, things of that nature with the Evo Guided. And maybe some of the panelists can speak to us about those issues.
I'd like to add, normally my assistants do all the deliveries, so I thought, ugh, I don't even know how easy they are to deliver, but luckily I got to deliver one today. Patient had never worn anything in his mouth. And I thought, oh gosh, I hope this isn't too tight. I hope it's great. And let me tell you, it went in like a charm. It came out like a charm. The patient was like, oh, this is comfortable. I didn't know what to expect. And as always with Prosomnus, I know that it's going to be a good fit and I'm not going to have to fiddle with them because there's nothing I hate more than that. But these go in very easily. And I just think they're a great appliance. And it was nice. It took me hardly any time to deliver and then go over the instructions with the patient. So is it better than the other cases? I think so, because there's just less bulk. By having that lingualist design, there's less undercuts for the appliance to engage. So very easy.
And Eddie, I know that there were some questions in the chat about strength and retention.
Okay.
And as you know, we've done quite a few of these, and we have not had one single fin break. They're longer. That's one thing I was concerned about. No breakage, and I haven't had a single report about them being loose or coming loose during sleep. So I don't think retention is a problem, and I don't think breakage is a problem.
That's great to hear.
Our company-wide quality data would confirm that. It's off to again, it's early days in the launch of the product, but the early results show very good robustness and durability and good fit rates of things not being too tight or being too loose, and overall durability. So it does seem to be off to a good start. It seems to be affirming, Dr. Smith, what you're seeing in your clinic.
And to
And if
Ken's
you
point, I'm sorry, to Ken's point, that long lower post at first looks a little intimidating, but it's really tapered just nice, and so that on delivery, patients put it in and they don't even feel like there's any bulk there. It really seems to really kind of be streamlined very nicely on delivery. Patients right away feel comfortable. They don't feel any bulkiness or anything sticking out, which occasionally we would get with the Evo, where it felt like that vertical post was maybe a little wide. But this really works great. People are very happy patients here.
You do have to be careful about maxillary tori. We have found a few patients that it does irritate that.
Okay.
So, but having said that, we're able to adjust it. And I shouldn't say this if Sung is in the room, but
he is listening in.
and that has been able to fix it. So you might find that it does hit the upper gingiva on some thinner patients, and especially if they've got some maxillary tori. So just kind of be aware of that. You can adjust it.
Yeah, I had that discussion today with one of my staff about exostoses because this one patient had an exostoses above and the post being taller impinged on that. So I would tell them to feel if there's any exostoses, like you said, a tori on the buccal plates, to make sure they get that in the scan so the lab can adjust. And they may have to just open up the vertical another 0.5 millimeter if it's not counterproductive, just to get that space, or you can maybe shorten and taper the top of that lower fin.
That was exactly what I was going to mention. So if you have any area that you're concerned, just scan it. Then we'll make sure that doesn't create static issue.
I got you, Sung. I got you.
Yeah, Heather took Sung off mute for that one. Thanks, Heather.
Great point. Now with the scans, when you get good data in, you're going to get a good result out. So yeah, picking up even more of the soft tissue is probably a great tip for listening.
I love placements. They're easy. They don't take much time. I used to kid Wally that I got to warm up my pitching arm because I throw them at the patient. They open their mouth and go right in. It's not exactly true, but if you've done some of the legacy devices or really want to torment yourself, go back to doing one. But with the shrinkage that takes place, that's where they move teeth. But also you spend a lot of chair time adapting and adjusting those so they'll fit.
Right on. A question for Dr. Utterback, if you don't mind. I don't know if it's specifically directed to you, but I'm going to throw it in your direction. Question is, one of my local sleep physicians says oral appliances are only 50% effective in reducing OSA versus CPAP, which is 95%. What would you say to that local physician? Maybe Dr. Utterback can start us off here, and then everyone else can jump in.
I came into dental sleep medicine about 7 years ago, and in my area, it's extremely conservative. When I first started, I would only get the CPAP intolerant patients, maybe AHI under 10. And I think it was a lot on my part to start keeping data. And then I would randomly just send them efficacy reports that we do in our office. Every 50 cases we do, we send out all of our referrals to show them. We don't sugarcoat anything, and we just get the conversation going. And I think over time, I think the physicians realize that, you're more than a dentist. You're looking out for the overall health of this patient, trying to do your best, trying to improve your techniques, improve your appliances. But you have to learn to make those connections. And I think that's one of the biggest hurdles in dental sleep medicine is a lot of dentists that I talk to say, I just can't crack into that physician network, but you have to be patient and you have to feel confident in yourself to talk to them because I think the overall consensus is they tend to look down on us as dentists, that we're kind of stepping on their toes with what we're doing. But I think once you start, producing some good results, they start to trust you. And I have physicians that reach out to me sometimes and say, hey, do you think this patient would be a good fit for an oral appliance? So it takes time. You got to be patient with it, but it works.
Thank you. Any other comments on that one or anything else you might suggest saying to that local physician?
Yeah, I would just say you must be talking about the morbidly obese severe patient if you're saying 50%, because they're just as effective as CPAP in mild and moderates. And even some of our severe patients, it's very effective. So I'm not sure where you're getting your statistics.
I agree with Dr. Smith, and I'll add one other thing to it. When I say to them, they say, "Oh, it's only 50% effective." I go, "Are you just talking about all levels of sleep apnea, or mild, moderate, taking out severe?" And then I say, "What study are you looking at?" Because a lot of them, and a lot of this literature. And I just I gave a lecture at a recent sleep meeting when I discussed this. It's great to quote the literature, but the literature that's so old doesn't address the new devices that have been out and all the new studies that ProSomnus is showing. So when they say, well, I'm looking at this study, I go, the study's from 2006. You're looking at an efficacy study that's 15 years old, 10 years old. Let's look at the studies that are recent. So I bring them studies that are recent in the last 2 to 3 years that are made on the devices that are current, so they see a difference, and that really has big change for me.
Yeah, I think that's why I'm so excited about the device that Dr. Smith has been wearing, getting 100% scores on every night is I think the combination of a modern precision oral device with kind of real-time nightly oximetry to help with titration, objective-based titration or outcome-based titration is really going to be a dramatic game changer for our field. I think Dr. Tozer, some of the poster you shared at AASM certainly seems to reinforce that notion. And I'm just looking at some data from Dr. Hedgecock and Kerr out of Austin, where they're using a similar kind of titration study protocol, and their results are phenomenal. The combination of the high performance precision devices with the titration decisions being driven by that information.
I always go at them with the Boyd analysis, effective AHI, time with the CPAP on versus time with it off. They can't cherry pick and say, yeah, when they wear it the 4.5 hours, it's 95% effective. But let's have them turn into a 30 AHI for the second half of the night. What's their true resulting AHI? And then we can go a step further and talk about the SURE analysis, where it's okay on your medical guys who are placing Inspire that a 50% reduction or an AHI below 20 is considered effective. We turn a 50 into a 9 and we get our patients shipped back to us, get that 9 to a 5. Yet you send your Inspire patients back to them to crank up the voltage, or, let's be fair in this analysis, right? So usually, obviously you're saying that in a nice way. We know that most of the majority of the patients do not wear the CPAP all night. And when you take in the hours of usage of the oral appliance, it makes up that gap without, obvious side effects of intolerance.
And just to add to that, we have Zepbound now because
yeah,
we have a lot of patients calling us. Their cardiologists tell them, get a test because if you have sleep apnea, I can write you the prescription. And that was cleared taking a patient with AHI of 56 down to 25.
Mm-hmm.
Whereas if I brought that to a sleep physician, they would say, told you your appliance isn't working. They're still
right.
high moderate, but it's Zepbound now. They want to write for sleep apnea. So,
and it's taken a lot of our severes down to moderate to mild, which then makes them more of a candidacy for oral appliance. So it is our friend in essence that if you lower their severity, they're more likely to send them to us, right? Versus they're still obese and have a 65 AHI, they're less likely. So, hey, you don't like to wear the CPAP. This is what my sleep physician tells her patients. If you don't like to wear the CPAP, let's go on Zepbound. Let's lower your BMI. Then I'll get you to Dr. Federici for the appliance. Happy medium. And it's like, deal. So we're going to see more from the Zepbound patients, whether it's microdosing that they can't handle long-term, that they're going to go off of it, but they want to pass the baton to an oral appliance. Now we've got to, again, tell them, hey, get your weight loss, keep it down, exercise more, right? Lifestyle changes so you can stay in this range so your doctor doesn't get concerned that the appliance may not work anymore, or they're going to put you back on CPAP. So if you all talk to each other and say, hey, we're a team, let's get you healthy as possible, then nothing bad can happen from that.
Another question from participants. Can you use the Evo guided with patients who are mild to moderate clencher bruxers?
Yes.
Excellent. Do you consider patients that have forward head posture and scoliosis to have a different appliance position?
It's an interesting question. I never really thought about that. Any of the panelists want to bail me out?
Well,
Yeah.
I've never seen a patient with that condition, so it's hard for me to assess that at all.
So forward head position and scoliosis, we see it and we talk about it, but then also remember the patients are laying down. I have lots of patients ask me about their pillows. I feel like a chiropractor at time because I'm always talking about neutral spine. You don't want to tilt the head too far down, too far to the side. But I would say with the patient who has a significant hump or dowager's hump or curve. You just want to make sure, again, that their neck is supported and their appliance position is going to be the same as all your other patients because they're laying down and hopefully on their side and not their back.
Thank you. Question specifically for Dr. Smith. How do you decide CO versus further protrusion as a starting point?
Well, those are our pretty mild patients or our primary snorers. So I don't, if it's a moderate patient, we'll probably start them out at like 25%, something like that. But yeah, the CO, just to, as was mentioned, if you start them without any protrusion at all, you can mitigate some of those potential side effects. So rather not have a bite change if we don't have to. So why not start them out and see if it fixes them?
Their question, what about lateral bruxers? Any issues with dislodgement with those types of patients? Have you come across any of those concerns?
Not yet.
Okay. Thank you. Sorry, I'm just doing rapid fire speed dating here because the the participants, everyone who's on, they're asking questions, which is wonderful. Let's see.
We also have the lateral guide angle, the 4-degree left to right, so it kind of guides you into the midlines where his bite was taken.
I think, and there are a number of questions about, following up on the different types of oximeters that have been discussed, or some of the different studies that have been discussed. And I would just suggest email
email events.
Yeah,
Yeah,
email
we'll get a
events.
list. Yep.
And we'll answer those. Question for Dr. Tozzer. You shared your rapid titration protocol at the AADSM in Vegas. How has that helped in this conversation with your referring doctors?
It helps because I can show them the during as well as the after. They get to see the results. Also, it illustrates what I was alluding to earlier, that once you get past the optimal point, it actually degrades the results. So some of the docs are really into it. They want to know everything. Some of them say, show me the after. That's all I want to see.
I think Dana had made a good point earlier that ask the doctor. Some don't need any more paperwork. Just send me at the end. Other ones want everything, and then there's ones in between. So my staff just take, hey, what would the doctor like? My titration report, see how they're doing. Send me to me when we're ready for the efficacy test. I have too much going on. I trust you, and obviously that may start out that way, but as you become more successful and gain their confidence, they're less likely going to want to see every little patient's notes from you. And like Dr. Saul said, some are just swamped doing, 200 HST interpretations a month. It can't be reading letters from me saying, hey, how are the kids? I just want to show you this new patient. It's like they don't have enough time. So again, just do a poll with your staff, to their staff. What would the doctor like? And that way it simplifies it and you're not over or under supporting your documentation.
What's interesting about the over protrusion, I think, Dave, you might have been at this. It was one of the meetings at BEDSMA in Belgium, and there was a dentist from Italy that presented a paper on protrusion and how you remember that? And so it's interesting if you think about the fact that there is a significant amount of evidence right now that over protruding can be detrimental, and whether it has something to do with loop gain, we don't really know, but it certainly argues for the fact that the minimal protrusion is a better strategy. And if we're going to reach the endpoint with minimal protrusion, and we have a device that allows us to have more space for the tongue, more forward movement of the tongue, then certainly from a design feature that's very critical in achieving that endpoint.
That was music to my ears when I heard it, because I'm more than one of the conservative people, but everybody, that's the beauty of this panel, right? Everybody has their own way. It's sort of like composite. Sure. When you're a dentist and adhesive, what do you use? Well, whatever works for you, right? and that's the way we shouldn't be. It's take everybody, all panelists, and apply bits and pieces and try different things. It's not like you're stuck and forcing yourself to use this pulse oximeter or start at this range or this position, But just like Dr. Tozer says, you don't know what you don't know. And how do you send them back for an efficacy test? If the amount of weeks, well, what have you done in those weeks? If it's a time frame you like to get them for an efficacy test, where do you determine the endpoint? Is it on subjective symptoms? And again, with my history, with my patient pools, that I had a lot of patients who had not been completely resolved numerically, yet felt wonderful. So if I had gone strictly on subjectives, I'd probably be batting 60% or 600%, you know, batting 600 in baseball. Like every 4 of those patients wouldn't have been ideal, yet they felt ideal. So that's my philosophy on titrating with pulse oximetry is I get that targeted endpoint and I know I'm done, right? I've actually gotten to the point where I'm not taking a shot in the dark, and there's less likely of getting a return patient back saying, could you titrate a little further because their efficacy test came in at 11 and they started at 19, and I'd really like to have that a little bit better. And I said, okay, you know, historically I used to do that, but now I'm trying to get them down to that lowest amount possible. And that's where the titration using the high resolution pulse oximetry affords me to get to, so that it gives me more of a confirmation that I'm done, if that makes sense.
For sure.
Dr. Saul, this is a question for you. How
Uh-oh.
helpful is the Evo guided for patients that have a larger or elongated uvulas to control snoring?
Well, you know, I mean, we don't have data on that specifically, but you know, certainly by the design, you would hypothesize that there would be more room to move the ventral surface of the uvula forward, you know, as to whether or not it specifically addresses the length of the uvula. I don't know, but you know, certainly the design is going to make it more physiologic and more anatomic, I would think.
Another question. The panelists were mentioning that get to an ideal position sooner with Evo guided. If I would normally start a patient at 60% protrusion, would I start at 50% instead? Of course, knowing that each case is a little bit different. What would be your advice if they normally start at 60%? Would you back them off to 50%, or would you go to more of a CO, or what would you advise?
Well, studies show that if you start at 50%, your side effects can go up exponentially. That's been proven. So I never start somebody at 50%. I just think with forward position adjustments in the Evo guide, you can get there if needed. So why introduce some possibility of being too far forward or increasing jaw muscle discomfort? So try starting out at 35% if you think that's, and see what the kind of symptoms the patient has. Do some of the testing that some of the other clinicians use with pulse oximetry before you start just going back 10%. I would say start there, and then you can bring them forward in about a week or two and see where you're at. I just think 50% starting for every patient, unless they're maybe super severe, as Dr. Smith was saying, I think could be a little bit too far forward, too fast, and unnecessary.
Question about side effects. Do you see any occlusal changes or tooth movements with the Evo guided, given that it has less coverage or doesn't have lingual coverage?
Well, it's too early to tell. I mean, side effects usually occur within 2-3 months of wearing a device. But I still feel that, and I've also noticed, and I know I talked to Sung about this on a phone call, where one of my patients had very short mandibular teeth, and the appliance came back, and he said, "Look, when we look at that, even though we wanted lingualists, we're going to take some of those lower molars and just come over a teeny bit on the lingual, because we know that it's going to have to fit that way because of the patient's shorter teeth." And so I still think that has a retainer-like fit. It doesn't just cover, it's not just on the facial of the lower anteriors, it does come over a little bit. So you're still getting all these teeth locking in for tooth movement. I don't see there's going to be any difference in tooth movement in the long run, but I think it's kind of early to see if you see any of that with it only being out, even the ones I've done, it's now 6 months or so. I think it's a little early to tell on those.
And most of your force vector is going to be mesial distal as well, not buccal lingual. So just make sure you have that distal wrap to keep everything tight, because you'll get posterior diastemas that'll start if you don't do a distal wrap. So that's my recommendation to minimize tooth movement.
A related question to the Bruxing question from earlier. How do patients do with guided if they have midline discrepancies of several millimeters or shifting during protrusion?
I would say it's like any other appliance. When you're taking your, say, your protrusive bites, see where their midline is there. For instance, if they deviate to the right a millimeter with their bite, well, you are going to duplicate that with your appliance. So the guided is no different than any other appliance that you're taking a bite for. In other words, the wings, even though they have the 5-degree posterior guide, it's not going to change their protrusive movement.
Yeah, and I think one of the things that happens is ProSomnus is so good with their communication that if they think the bite is off that 4 or 5 millimeters, they're going to tell you, hey, is this the correct position for that protrusive bite? So one of the things that we've always done, I think it's a good recommendation, is to in your portal script is to say, look, this patient is has a deviation or of 3 to 5 millimeters, whatever it is, to the right, so that when they design it, they already know that that's there, and they don't have to question it because they're looking at midlines. They're not knowing what the patient's doing with their muscles when they protrude. So I think if you tell them ahead of time, you'll have a smoother transition to the design team.
And the question might have been asking, what if they need to go laterally? Then we can build in more post space, extra 2 millimeters on each side to allow them to deviate as they go forward. Or so there's a click. Is it 2 millimeters is standard and it goes to 4 is the option on the portal? 4 millimeters inner post space, some that they can increase between the space between the posts.
I think 3 is standard, Kevin, if I'm not incorrect.
3 is standard.
So when you ask for more, it goes to 4, so you get a 0.5 millimeter more on each side. Correct. So if that patient needs to deviate, if their natural protrusion has them deviating, the posts can be moved further away from each other to allow that deviation to occur as you're protruding, so as to not create those interferences or possibly with a bruxer or a side sleeper put stress, possibly fracture that post.
Yes.
Heather, how are we doing for time? I know it's late on the East Coast. Want to make sure that we're
yeah, I think we had a few more slides at the end, but these are all really good questions too. So
let me do one more question and then we'll finish up the slides. That's okay.
Yeah.
So based on your experience with Evo Guided so far, do you think there's something to this idea of hyoglossal repositioning and that the tongue space is making a difference, or is it really just marketing language? What would you say based on your clinical experiences?
I want to add, I'd like to add the first night I wore mine at a conference, I just felt like I could breathe better. So knowing that your tongue can rest in the roof of the mouth where it belongs, there's nothing adhering or preventing that from happening. And then just think if we have learned about myofunctional therapy, the goal is to keep the tongue in the roof of the mouth, which keeps it forward, which encourages nasal breathing. And that's what this appliance is doing. And I think it's huge, the difference that it makes. And it's just so comfortable. So it's not marketing gimmick.
Thanks. It wasn't intended to be. I can vouch that Dr. Remmers hit the books pretty hard in looking at the pathophysiology research, which is not easy stuff to read. He had a couple bourbons while he was doing it, for sure.
I think Dr. Saul's going to take about 10 Evo guided patients and put them in the sleep lab and do some dice studies and check that collapse at the velopharynx and oropharynx for us. What do you think, Dr. Saul?
We could do it.
Yeah,
for sure.
Well, Dr. Kroll, that's why it was serendipitous that I logged in to PubMed one day and there was Dr. Ryan Seuss's paper where he was looking at non-responders and found that they all had velopharyngeal collapse and they were using a traditional device.
So I think if that's a great article, if we can now do a study to show with the dice how this could correct that, I think
Yes.
that really could be ground changing for us.
Yeah. Well said. That's the right way to do it. Good. Okay, well, there are several more questions, and just wonderful to see so many familiar faces and friends and colleagues who are participating and commenting in chat and being on the webinar. And just I just want to say thank you to the panelists before Heather goes into the closing here. Wonderful discussion. Thank you all for sharing your time and your expertise. And it's a true pleasure for us. Thank you for me.
Thanks for having us.
Thank you.
I
Thank
think
you.
we answered a lot of those questions.
Yes.
Let's see, we'll go back. So I think we have Jerry and Stacy on from our North American sales team. I think they wanted to just share a new Medicare bundle program that we have available to providers. Jerry, Stacy, if you wanted to quickly cover this for our audience.
Great. Thank you, Heather. Appreciate it. We've been talking so much about old studies and old habits and old opinions, things of that sort. And we as a company have been talking a lot about efficacy, about patient comfort, and we consider ourselves to be true OSA advocates. And I especially am sensitive to this particular group right here, the Medicare bundle, the Medicare group that is prominent in our population with this disease. And so why is that so important to us? Well, not only is the population growing, I'm part of it. So I've been wearing a device for 20 years. And so when you guys talk historically about people's opinions, et cetera, and so on. It goes to the patient level too. For those of us that have been in therapy for so long, I had some pretty bulky things in my mouth, and there was a lot of reasons why I came to ProSomnus. And the fact that we were focusing on the patient was really significant to me because I come from the medical industry. So we have the Medicare patients, and there's no reason in my mind. I think it's a tragedy that, in fact, our senior citizens are being burdened with wearing a device with a big, bulky metal piece in it that if you had to try to get a screw into it, et cetera, and so on, it just makes no sense whatsoever that population is being subjected to care that was designed 20 years ago. Additionally, so if we're just replacing arches, certainly they can help titrate themselves and help themselves as well. Of course, continuous care is just something that's become really important. And in this population, the severity and the risks are very, very serious. So if they have a device that is a herpes device or any other device for that matter, and it fails, they have to wait and they're going without a device for some time. And that is absolutely frightening to me for someone, a Medicare patient, an older patient, to be subject to that downtime. It's really scary. And we came out. We started, Lennon, when I came here, we were at that moment dedicated to OSA and OSA patients. So we talk about the company being different, but the company is the same. And Select and Guided are just perfect examples of that. And getting rid of metal, that shouldn't be a question to anyone anymore. It's just really, really horrific that seniors are being subjected to that. So we said, well, how do we then help that? And what can we do? So we have a Medicare bundle program, and that is for Medicare patients, if in fact you want to, at the time of ordering the required reimbursable device that needs to have a fixed metal hinge, don't get me started again. We do have an upgrade program that's included with that at that time of purchase, they can get a guided device and improve their quality of life and have them probably be far more compliant in using the device than they are with these old style devices. So
Thank
we
you,
do have
Jerry.
it. So talk. Yep. Somebody say
Oh, did
something?
you have more on that?
No, I was just going to say, so, reach out to your rep, and that's where I was going to be going right now is reach out to your rep. We've recently added 2 new reps. We're continuing to expand, and we hope that process will continue to expand our team. And Stacy and I are just more than honored to be able to represent this group that's here, that is committed. They are all patient advocates. And, I just hope that you're all getting the satisfaction that you need and the service you need from all of them. If you're not, please take note of my telephone number and my email number and call me and let me know, because 100% in efficacy is not only what we're striving. We want to be the best sales organization. We consider ourselves now to perhaps be that, but we want to make sure we are. So we need your feedback in making this team even better than they are. And to top it all off, Kevin, you talk about the real team. Here we go.
Thanks, Jerry. And thank everyone for joining the webinar. My name is Kevin. I'm the Director of Customer Care Team here at ProSomnus. Customer Care Team's main goal is to make sure that we are providing the best treatment for your patients. As you can see from the map below, each representative is dedicated to a particular state. The team will be able to assist you with any technical questions that you may have. So that could be questions on bites, when the case will be delivered, or if you're having any kind of technical issues, feel free to reach out to them. If you're unsure of who your customer care rep is, please reach out to your local sales rep or email us at technicalservices@ProSomnus. I'm always available as well. My email is on the slide. And so now I'll turn it back to Jerry and Heather.
Thanks, Kevin. And yeah, we can, I can put in the chat, it's technical service at prosomnus.com for any of the customer care team. If you have any questions, you can always email events@prosomnus.com. Some of those items, the scientific compendium, the list of the different pulse ox options, we'll get all that out to everybody. I think that there was a few more questions in the chat that maybe we might have missed, but I'm happy to follow up with anyone individually if you have additional questions. I didn't know if the panelists had any final thoughts or anything that they wanted to maybe add about their experience prescribing Evo Guided.
I think the point was already made. If you haven't worn one yourself, if you wear one, a different style, and then wear this, you're going to see the difference.
And initial patient response has all been positive. So very excited as time goes on to see more data. Particularly Kent, I'm sure I'll have quite a bit to kind of back up what we're all saying here. Everything sounds positive at the moment.
And maybe to close a little bit with how we began. So Dr. Smith, if you kind of roll back the clock 20 years to think about what dental sleep medicine was 20 years ago, which I bring up because I think, to the point made earlier, many of the papers that create the clinical practice guidelines and many of the papers that shape the physician's current expectations about dental sleep medicine were performed clinically 20 years ago, literally. So if you think back 20 years, Dr. Smith, how has dental sleep medicine changed? It's probably a whole webinar in of itself, but
Yeah.
but
I mean, everything has changed in sleep. We couldn't do HSTs back then 20 years ago. They weren't around. John Rimmers came out with the first one, and now he's with ProSomnus, and we used the Rimmers recorder way back then, first one out. But yeah, it's changed so much, and I think it's for the good. I mean, I think dental sleep medicine is an extremely fast growing field in healthcare, and I think everyone should be jumping on board. It's going great places.
Couldn't agree more. Couldn't agree more.
All right. Well, thank you, everyone. And I really thank you to the panelists for joining us. I know we kept you well into your evenings, especially those on the East Coast. So thank you so much for your time and your support and all that you do for your patients. We really value what you do.
Yeah, I need to get to sleep so I get 100% on my RPMO2 sleep score. So it's cutting into my sleep time.
He's going to catch it, Kent.
So bad.
There it is.
Oh, man. Maybe I should move to Hawaii. I'll have a better chance of getting some sleep there. Yeah. Thanks. Thanks, everyone, so much. Grateful. Have a wonderful evening, and we'll all be in touch soon. Thank you.
Right, thank you.
Thank you so much.
Thanks, everyone.
Thank you, everyone, for
Thank you.
joining.
Good to see you. Thank you.
Thank you. Good night.
Thanks.